First of all, welcome everyone to NANSIG's inaugural journal club with Professor Roberts. Just to quickly introduce myself, so my name is Robin Borchert. I'm the clinical research lead for NANSIG, and I'll be chairing the event. And before we launch into the presentation, I just want to briefly highlight what NANSIG does. So NANSIG stands for Neurology and Neurosurgery, Neurology and Neurosurgery Interest Group. We're based in the UK and Ireland, and at the moment we're also expanding internationally. We have a main national committee of around 10 to 12 people, but we also have representatives at each medical school. So what we've been aiming to do, especially this year, is really focus on research. So we conduct national projects where we have the representatives from each medical school form teams, collect data. We mainly do audits, but this year we're also trying to arrange a prospective cohort study, specifically looking at low molecular weight heparin and its role in TBI. So we're particularly happy to have Professor Roberts with us. We also run workshops. We have careers days. We do educational resources, which we've been releasing via YouTube and Instagram. We also have an essay competition underway at the moment. So there are 2 essay questions, one about recent discoveries in neuroscience, one about future discoveries in neuroscience. And the winners of each of those categories will actually be published in either the Cambridge Medicine Journal or the British Student Doctor Journal. Yeah, so moving on to today's event, we're really honored to have Professor Roberts with us. We're kind of playing things by ear because considering the current situation, Professor Roberts has been called in to help out with the situation in the NHS. So he's currently on his mobile. So what I'm going to do is I'm going to have some slides of his in the background, and he's going to talk through his research, and I'm going to just kind of go through those slides as he speaks. And at the end, we'll ask him some questions. I have some questions that people submitted from the sign-up form. And if you have any additional questions during this talk, please just submit them to me. I'll try to fit them in. And now to introduce our speaker for the evening. So Ian Roberts is the professor of epidemiology at the London School of Hygiene and Tropical Medicine. He trained as a pediatrician in the UK and then in epidemiology at the University of Auckland, New Zealand, and McGill University in Canada. He's a clinical academic who works collaboratively with health professionals worldwide to conduct large multi-center clinical trials aimed at improving patient outcomes in life-threatening emergencies. He has over 40,000 citations and has published numerous papers in the Lancet and the BMJ throughout his career, as well as several systematic reviews in the Cochrane database. All right, Professor Roberts, are you here?
I'm there, yeah, I'm here.
Okay, I'm handing over to you now.
All right, well, hello, everybody. In this strangest of times, I expected to be doing this from my office, my computer, but in fact I'm now on a mobile phone standing outside of Waterloo Station. So if you hear trains in the background, that's what it is. So I'll kick off by giving some background to the CRASH-3 trial, and the background starts with the CRASH-2 trial. So about 10 years ago, we got very interested in a drug called tranexamic acid because the evidence, randomized trials in surgery showed that tranexamic acid really did reduce bleeding. And the evidence from surgery is really compelling. There's tens of thousands of patients in randomized trials. And you get these highly significant 1/3 reduction in blood loss in elective surgery. And no apparent increase in vascular occlusive events. So it sounded like a good drug. It sounded like something that stops bleeding and doesn't cause vascular occlusive events. So, I mean, it doesn't take a rocket scientist to realize that, well, okay, trauma patients bleed. And so, if tranexamic acid is so effective in surgical bleeding, maybe it will also be effective in traumatic hemorrhage. And so we did this big randomized trial called CRASH-2. We randomized 20,000 bleeding trauma patients. 10,000 got tranexamic acid, 10,000 got placebo. We just got this wonderful results. It was really spectacular. There was a significant reduction in death due to bleeding with tranexamic acid, a significant reduction in all-cause mortality, and no increase. In fact, looked more like a decrease in the risk of vascular occlusive events. So that was a very nice result. We were overjoyed by it, and it went into clinical guidelines. But people then said, well, what about isolated traumatic brain injury? You know, some of the patients in the CRASH-2 trial had both extracranial and intracranial injury, but it wasn't predominantly a head injury trial. They had to have extracranial injury in order to get in, and so people wondered, well, you know, should we say that tranexamic acid should also be used in isolated traumatic brain injury? And so it was an uncertainty, and in fact, UK guidelines and different guidelines by people around the country, around the world. Made isolated traumatic brain injury an exclusion for the use. So I should say that on the basis of the CRASH-2 trial, paramedics started using tranexamic acid in ambulances because we found good evidence that early treatment was most effective. And isolated traumatic brain injury was an exception. So we thought, well, does it need to be an exception? You know, is there any reason why it should be an exception? But it didn't seem to be, because it seemed to be that patients with isolated traumatic brain injury get the same kind of coagulopathy as patients with extracranial hemorrhage. So they get, you know, an early increase in fibrinolysis manifesting as in, D-dimers and basically the physiology, the pathophysiology of trauma with bleeding into the brain and bleeding into the body was pretty similar. And so CRASH-3 was launched to look to resolve the uncertainty around the effect of tranexamic acid in isolated traumatic brain injury. And then we randomized about 13,000 patients. Half got tranexamic acid, half got placebo. And yeah, we got a very interesting result. I'll describe the result qualitatively because I can almost remember the exact figures, but standing outside Waterloo Station, I'm not sure if I can remember them all. But basically, the primary endpoint was head injury death amongst patients treated within 3 hours of their injury. Now, when we started the CRASH-3 trial, the inclusion criteria was up to 8 hours. And that's because we started the CRASH-3 trial shortly after the CRASH-2 trial and before we'd really understood the results of the CRASH-2 trial. But when we analysed properly the CRASH-2 trial, it was really apparent that there was a very strong time to treatment interaction. So that's a sort of fancy statistical phrase. That means the treatment effect varies with time. And in this case, the treatment effect was much bigger when you give the treatment soon after injury, and it got less and less and less as time went on, until after about 3 hours, there was no tangible treatment benefit at all. So we got to understand the CRASH-2 trial results better. We started to look at this time to treatment interaction. We started to find it was very biologically plausible, bearing in mind the pathophysiology. And the pathophysiology showed that people get this early release of tissue plasminogen activator from the endothelium, and that stimulates the process of fibrinolysis. But then a little bit later, this enzyme called PI1 wakes up and closes everything down. So and it was all, starts to wake up about 2 or 3 hours. So it all fit with the idea that the treatment should be more effective early. And of course, the other thing is that people bleed into their brains very early. So, someone crashes their motorbike, moment of impact, there's, probably, bleeding starts, but it continues. And so you want to intervene early because tranexamic acid doesn't do anything for the blood that's already there. It can only reduce further bleeding. So sort of, I don't know if it was halfway or 3/4 or something, or less than that, but maybe after about the first third of the randomized patients, we changed the inclusion window from 8 hours to 3 hours. And we made that the primary endpoint. So we were looking at head injury death among patients treated within 3 hours of their injury. And we chose head injury death because it's just a matter of sort of signal and noise. Like, some people have a head injury, but they don't die of the head injury. They die of something else. I mean, you know, for example, we had patients who tried to kill themselves by swallowing organophosphates and then jumping off a building. They didn't die of their head injury, but they died of organophosphate poisoning. Now, the trial treatment, tranexamic acid, is treatment for bleeding. It's not a treatment for poisoning. And so these poisonings or whatever, or these other causes of death that are unaffected by the trial treatment, they're just sort of randomly scattered across the two arms, but it just sort of dilutes the treatment effect towards the null. And I don't know, after the trial, this seemed to be a sort of controversial thing. Everybody says, well, show me all-cause mortality. But it's not controversial in other areas of clinical practice at all. So cardiology trials always have cardiovascular events, not all-cause mortality as the primary endpoint. And, you know, breast cancer trials have cancer death. They don't include deaths unrelated to cancer. So that was it. So we decided to go for head injury death among patients treated within 3 hours of injury. And then we got this result. And the overall result was something like a relative risk, which is the risk of death in the treated group divided by the risk of death in the untreated group, of about 0.9293 or something like that. And we'd pre-specified also, because one of the things that we noticed as the trial was going along is a lot of patients were being recruited who had a very very bad prognosis at baseline. So we got many more patients than we had expected who had a GCS of 3 and bilateral unresponsive pupils. And so before seeing any of the results, we reasoned that we're unlikely to see much of a treatment effect in that group, and that they're going to bias the treatment effect towards the null too. Because, you know, if you just, you know, to put it in a very crude terms, if you include lots of people who are sort of dead at baseline or highly likely to die at baseline, then they're going to be the same in the two groups, and that will dilute the treatment effect towards the null. So we got this sort of modest reduction in the risk of death with tranexamic acid. And then when we had this subgroup analysis where we excluded patients who had unsurvivable injuries at baseline, we got a bigger treatment effect. That was I think the relative risk something like 0.89 or 0.9 or something like that. And I mean, and then we were quite excited by that because a 10% reduction in head injury death was quite nice. And you've got to sort of see it in its context, really, because, you know, this is a inexpensive, widely practicable treatment. Head injury is a mass disease. There's about, 3,000 patients will die of head injuries tonight. So, you know, it's a huge global problem. And if you could just reduce the death rate by, you know, just shave a few percent off the death rate, that would be very nice. Or even 1% off the death rate. So a relative risk of 0.9 or thereabouts would, you know, that's an interesting result. And then it got a little bit, and then we started looking at our pre-specified subgroups, which were severity was one of them. And we found that it seemed to be more effective in patients with mild and moderate head injury and less effective in patients with severe head injury. And and it kind of fits with a sort of, it's a similar idea to this idea that, patients who've already got extensive intracranial bleeding and a very poor prognosis have little potential to benefit. So patients with a GCS of 4, 5, 6, often they've got, they had big intracranial bleeds at baseline, and so tranexamic acid can't take that out. It can only, it's a preventative treatment. So we didn't see a very big effect in patients with severe head injury. In fact, we didn't see any effect at all, or next to nothing, but quite a big effect in patients with mild and moderate head injury. I mean, very big effect. It's almost like a 25% reduction in the risk of death. And in those patients who had mild moderate head injury, there was also a time to treatment interaction, the same thing we found in the CRASH-2 trial, such that the sooner you gave the treatment, the better. I think that's pretty much the main result, which was that's the main result. And then other results, we didn't see any increase or decrease in disability. We didn't see any increase or decrease in vascular occlusive events or any sort of other adverse effects. We hadn't seen any in the CRASH-2 trial, and we didn't see anything in the CRASH-3 trial. So it's not a particularly dangerous drug. I think, drugs certainly can have side effects, and the one we would worry about in relation to tranexamic acid is vascular occlusive events. We just didn't find any evidence of it, and trials in surgery and the CRASH-2 trial didn't find any evidence of it either. So that was the main result, really, that early administration of tranexamic acid seems to, there's a modest reduction in the risk of death. The reduction is greater in patients with mild to moderate head injury. Didn't seem to have any adverse effects. I'm going to finish soon, but one of the important things is I think the CRASH-2, the CRASH-3 trial results shouldn't be looked at in isolation. It has to be understood in the context of the CRASH-2 trial. I like to think of it as one big trial, really. So CRASH-2 and CRASH-3, the same dose of the same drug in a very similar population of patients, one with isolated traumatic brain injury, one with a sort of mixed population of intracranial and extracranial injury, and they got broadly similar results. And so I think, coming back to the original question that motivated the trial in the first place, is there any need for this exclusion of patients with isolated traumatic brain injury? I think the answer is no. And just like, and the implication of a practice is that just give all trauma patients, whether they've got isolated traumatic brain injury or not, just give them a gram of tranexamic acid as soon as possible, preferably at the scene, and it'll probably make a bit of a difference. A meaningful difference. It's not. You're never going to get something that has a huge effect, because this is trauma, and the traumas happen, and we're only dealing with the consequences of the trauma, not the trauma itself. So if you want big treatment effects, you have to go to prevention. But preventing secondary damage due to intracranial hemorrhage or extracranial hemorrhage is worthwhile, and that can be achieved with tranexamic acid, I think. So that's it. I'll stop there, and then there might be questions.
Well, that was really interesting to hear about. I think what's also been equally interesting is seeing how quickly this has been introduced into practice, because I think your paper was published in October, and I started my A&E placement in Edinburgh in November, and already by then people were talking about it. It was being implemented into practice, so that's been super interesting too. So we had people kind of submit questions beforehand, so I
Yeah.
will just go through them and see what you think. So the first one is from Sanchita. She's from Cardiff. She asks, what is the role of setting training and guidelines for pre-hospital care providers, i.e. senior paramedics, pre-hospital critical care teams, etc., to be able to prescribe tranexamic acid to reduce delay in management?
I think this tranexamic acid, I'm glad that that question was asked. Tranexamic acid is a paramedic drug. Patients should have had the first gram of tranexamic acid at the scene. I'm working currently now with the army. We're trying to develop a tranexamic acid auto-injector that soldiers can use on the battlefield if they're, if they stand on a mine or something like that, and there's no medic close by. They can inject themselves with tranexamic acid. And so it's a really, it needs to be given as soon as possible. If, ideally the moment of impact, bam, right, that's it. Trauma has happened. Now give a gram of tranexamic acid. And so it's definitely paramedics where the action is here. The time to treatment interaction is really strong. So if you give, tranexamic acid within an hour of injury, you get a 30% reduction in hemorrhage death. And, 2 hours, give it 2 hours, 2 hours after impact, and it's it's like a 15% reduction. And then at 3 hours, there's actually no benefit at all. So it really does have to give them early, and paramedics is in the ambulance by paramedics or at the scene is where it should happen. So I hope it will go into paramedic guidelines. I know the JR in the UK, the JR Calc, they're called ambulance guidelines. They're either working on it. It's either already happened or they're working on it.
Fantastic. Thank you for that. The next question is from Mark in Nottingham. So he says, Dear Professor Roberts, was the number requiring subsequent cranial surgery investigated? So did tranexamic acid lead to fewer operations?
No, it didn't. It didn't lead to any increase or decrease in neurosurgical. In fact, when we were not really sure what to expect. It didn't really have any increase or decrease. It's a very difficult outcome to interpret, really. Because you can have more operations and that can be good, or you can have more operations and that can be bad. It depends. It depends on what compared to what, really. So you can imagine that, if it reduces intracranial bleeding, you can imagine someone who would have had a huge bleed that's inoperable now has an operable bleed, or it could have also mean that somebody who would have had an operable bleed doesn't have a bleed at all. So yeah, to cut a long story short, no, it didn't really have any impact either way. The only thing that we've actually shown that tranexamic acid really affects is the chance of dying. And it might be because death is a really good outcome in clinical trials. And it's a really good outcome in clinical trials because no one ever gets it wrong. It's measured accurately always. And, while we're doing these trials, we do a lot of data checking. And, you look at the disability data and there's an element of judgment, did this patient have a good outcome? And, there's an element of, I think there's probably more measurement error in that kind of outcome, the disability data, but the much less in death. So death is a very good outcome, and that's possibly why we got such clear results for death.
Fantastic. Okay. I've just received a question from someone in the chat, so Sumi Rat. So she's asking, I'd like to ask Professor Roberts, the confidence intervals for relative risk cross 1. How can we be sure that the reduction in relative risk is a significant result?
Well, that's a really good one, because that proved very sort of very controversial. And so a confidence interval is much more interesting than a p-value, right? So first of all, we have to think of what a p-value is. So what people do with a p-value, behind every p-value, there's something called a null hypothesis. So you go, the null hypothesis is that tranexamic acid has no beneficial effect at all. So the relative risk is 1, and the p-value, which is what's calculated, we didn't calculate it, but other people calculated it. We don't particularly. Anyway, let me finish with what p-values are. The p-value is the probability that if the null hypothesis is true, that you would get a treatment effect as big as you have seen, or bigger, by chance alone. So it's a very strange thing, a p-value. It's like, if this treatment really has no effect, what's the likelihood, what's the probability that you'd see a 10% reduction in head injury death by chance alone? And for some reason, it's not clear to me why, people have selected an arbitrary sort of probability value of 5%. And they kind of go, if the p-value is less than 0.05, the treatment works. And if the probability value, the p-value is greater than 0.05, the treatment doesn't work. Now that's really wasteful of information. Information isn't dichotomous, it's continuous. So I think it's a sort of dumbing down of results to go, right, what's the primary endpoint? What's the p-value? Greater than 0.05. Well, that's it. Not interested. That it's a sort of waste of information. I mean, I don't know if anybody can really argue that if the probability that if the results are true, you get a result as big as this by chance alone was 0.06, you're not interested. And if it was 0.049, you are. Now, in actual fact, the p-value for the main result, and the main result, I think, is the one that's not biased towards the null by the fact that all the people who are dead at baseline. So the p-value there was 0.056. So I don't know. I can't really get excited by people who sort of make a qualitative distinction between less than 0.05 and 0.056. And in general, I think p-values are not helpful and they should be sort of banned. And in fact, statisticians all around the world kind of agree with that. P-values are a sort of, I don't know, sort of, it's a sort of something we got from agricultural statistics that's not particularly helpful in medicine. And confidence intervals, on the other hand, which is where the question has started, are much more interesting. They give you, they're sort of a little bit conceptually complicated, but roughly speaking, they're the range of true values that are compatible with the trial result. And so, what you see is that, the best estimate of the effect of tranexamic acid is a 10% reduction in head injury death. Now, I'm slightly making up these confidence intervals because I can't remember them. I'm standing outside a railway station. But it could be a 20% reduction in head injury death, or there could be hardly any reduction at all. Now, that's a more interesting way to think of the results. You know, our best estimate is a 10% reduction, could be as big as a 20% reduction. We might have been unlucky and got it smaller, but we might have been lucky and it's actually smaller than that, you know. Now, the actual bound of the confidence interval, the upper bound of the confidence interval, is a very it's the least likely result. It's less. The most likely result is the point estimate itself, the 0.9, and the upper bound of the confidence interval is quite an unlikely result. When we did the upper bound of the confidence interval cross 1, we're wasting what a confidence interval is. We're turning it into a p-value, because what we're doing is we're actually taking this thing that actually has a lot of descriptive information and turning it into a hypothesis test and say, well, look, you know, because the upper bound of the confidence interval crosses 1, and that corresponds to a p-value of 0.05 if it's 95% confidence interval. You know, so we're sort of it's kind of an abuse of a confidence interval, I think. That's a bit of a nerdy thing to say, isn't it? So I'll stop there. I've tried to explain p-values and confidence intervals are very important, and it's you know, it's really, you know, so when you've got a quiet afternoon, sit down and really, you know, look into these. But I think p-values, and lots of people are coming around to the view that p-values are not helpful, and that actually we should see, you know, we just need to understand results, you know, for what they are and make judgments about them, and not sort of have this sharp dichotomous decision-making thing.
So I think we only have a few minutes left, so I think we'll end with this coming question. So this is from Shazan from the Medical University in Sofia, Bulgaria. She asks, how can medical students develop the skills necessary to succeed and develop such a monumental and beneficial global effort towards running a clinical trial?
Oh, well, I think the most amazing thing is that if you say you want to do something big, then people will say that they want to help you. Now, you know, we learned this from the cardiologists. When I was a junior hospital doctor, I suddenly realized that when you're a junior hospital doctor, you tend to be rather overconfident. And then as you go along, you realize, oh my goodness, how do we know if any of these treatments are effective? And so I remember getting a little bit skeptical, thinking, God, is there any evidence that any of this stuff works that we do, you know, in trauma care? And there isn't. There wasn't. There's some now. There's still huge evidence gaps. And then I started looking around at what speciality have really got to grips with evidence, and it was the cardiologists. And they did these big multinational trials where they had tens of thousands of patients, and they started finding really good answers. You know, they found, you know, aspirin, thrombolysis, and, you know, ACE inhibitors. You know, they found drugs that really do improve the outcome. And so we just try to copy them and say, well, look, trauma's a mass disease too. Can we do big trials in trauma? And then you start off a bit nervous and you think, well, can we? And then actually what you've got, it's almost like a confidence trick. You have to go, look, what we're going to do, you know, we're going to randomize 20,000 patients and see if this drug that reduces bleeding saves lives. And it's open to anyone, anywhere in the world who wants to help us answer this question, you just get loads of people who want to help. And especially if you say, you know, you say, well, look, it's not about me, it's about us, and it's about everybody. And so we have the sort of machine has a sort of ethic that, you know, we publish in the Lancet, and the reason we publish in the Lancet so much is the Lancet allows us to include everybody's names. And so we publish under this sort of collaborative name, like the CRASH-2 collaborators or the CRASH-3 collaborators. And at the back of the paper, we just put everybody's name and what they did. And people love that. You know, they think, right, I can contribute to something worthwhile. And that's how they work. You know, there's lots of people in the world who just feel that they're sort of excluded from the world of research. And these global trials, you know, large kind of streamlined trials, you know, not too much data collection, but you're collecting data on the important things. They let them come in, you know, and you get people all over the world, you know, and they become real champions, and they work really hard, and they're not doing it anything, you know, and we don't pay anybody. We don't pay the collaborators for we pay the, you know, we all out of pocket expenses we pay. But I suppose I keep on giving long answers, but the short answer is, if you try and if you want to do it, try, and you'll be surprised how many people come and help you.
Fantastic. All right, I think we're going to leave things there. Once again, a huge thank you to Professor Roberts for having us, for joining us, especially under these circumstances, and thank you for everyone for joining us. We'll probably have journal clubs around once a month. We're probably going to alternate between neurology and neurosurgery. So the next one we're hoping will be on the use of aspirin in hemorrhagic stroke. But look for updates about that. And yeah, so I think we'll draw this to a close. And thank you again, Professor Roberts.
Oh, well, thank you for organizing it, and thanks everybody who was listening. All right, take care.
All right, bye-bye.
Bye.